well, I think we should probably make a start so we keep to time. Welcome, everyone. My name's Tim Sladden. I'm an HIV advisor with UNFPA, the Population Fund, and it's my great pleasure to welcome you to this 5th Key Populations Community of Practice webinar. And today we're very pleased to present the updated World Health Organization Consolidated Guidelines on HIV, viral hepatitis and STIs for key populations. And this new consolidated guidance it's been pretty much 2 years in the making. So it's been a phenomenal effort with great involvement of experts, populations, community members, and development partners. And we're very delighted that we have an opportunity here to present the update and to hear more about it from WHO colleagues, and then have some discussion about how the guidance will be used. So we're going to summarize how it's been updated and what the changes are, one of them being that we have now broadened it to look at not just HIV, but other sexually transmitted infections and viral hepatitis. So I think that's an excellent development. So we're more people-centered and meeting the more integrated needs of people. We're going to hear about the evidence that was generated from both the communities and experts and implementers, and then look at how it's going to be implemented and some of the support that we need from donors and funders to take this forward. Now I'm just juggling screens here, so bear with me one moment. But the first off, we are going to hear a brief overview of the guidelines from Virginia Macdonald of WHO, who's going to really set the scene and take us through the update. Virginia, thanks very much. Virginia, are you there?
Yes, sorry, I'm here.
Yeah, there you are, right.
Yeah, sorry. Yeah, I was saying, thanks for having me, and thanks, Tim, for the introduction. And I ask for the next slide, please. Okay, and next slide, please. Okay, so I'm really happy to be here to present the key population guidelines, which have been updated and launched by WHO at the AIDS conference in Montreal. Today I'm going to discuss quickly the framework for the development of these guidelines, the methods we used, the recommended package. We have some new and some updated recommendations, and I will talk you through those. And then I'm going to briefly touch on the next steps. Next slide. So this is the framework which helps us to plan the guidelines and understand why we have to prioritize key populations in our response to HIV, viral hepatitis, and STIs. This is really what guides WHO and why in these guidelines we put key populations at the center of the response to these 3 disease areas. At the top of this figure, you will see we have stigma, criminalization, punitive and restrictive policies. And that's really recognizing that this is shared amongst our 5 key populations. Who are men who have sex with men, people who inject drugs, trans and gender diverse people, people in prisons and sex workers. So these are shared amongst those groups, this experience of stigma, criminalization and restrictive policies. And the knock-on effect of that is really violence and other human rights abuses and discrimination. There are intersections of unemployment, poverty, gender, race, disability, and education. And all of these in combine make it very difficult in many settings for key populations to access prevention, testing, and treatment services. it then makes it difficult to practice safe sex or safe injecting and can increase risk behaviours. And we have some biological factors and social factors. And all of these combine to make key populations at increased risks of not just HIV, but also viral hepatitis and STIs. And I'm glad that Tim really pointed out from the outset that what the main difference in these guidelines compared to the guidelines from 2014, and then they were updated in 2016, the main difference is that we now include viral hepatitis and STIs with equal attention and equal importance in these guidelines. Next slide, please. So after we've defined the problem, then we think about how can we address that problem? What are the steps we need to take to improve access to services for key populations? And at the top of this figure, we have the goals which we've all agreed on: to end AIDS, STI, and viral hepatitis as public health threats, and also to end discrimination. And none of these are possible without prioritising key populations and really putting them at the centre of the response. And underneath that, in order for us to prevent, diagnose, and treat these three disease areas in key populations, we need to make sure that there's equitable access to the services which are needed to do this. And the ways that we ensure access to those services are primarily to reduce those structural barriers, ending stigma and discrimination, decriminalising behaviours and sex work, adapting policy and addressing those violence and human rights violations. We also need an empowered community. We need service delivery approaches which increase access, such as decentralisation, task sharing. We need to provide an evidence-based and people-centred quality interventions. And this is really where WHO's methodology of setting new standards and developing new recommendations is really important. And we need to fund those interventions adequately. Next slide, please. So just briefly, how do we develop guidelines? Well, WHO has a very well-defined method for developing new recommendations, and we followed that. First of all, though, we looked at all the existing recommendations across the 3 disease areas and for the 5 populations. We wanted to look at what already exists among other WHO guidelines. So there's many WHO guidelines, including many recommendations. And some of these are relevant for our 5 populations across the 3 disease areas. So first of all, we looked at what exists already. And after this, it was easy for us to identify what needs to be newly developed. Really, where are the gaps in the evidence? And are there any recommendations that need to be updated? So we asked ourselves those 2 questions. And finally, well, not finally, next, we conduct an evidence review. This is mainly through systematic review of published literature, but also looking at the values and preferences of key populations. And we take that evidence to a guidelines development group, and using a methodology called GRADE, they discuss the evidence and form the recommendations that form part of our guidelines. And then we developed the guidelines, focusing on the new and updated recommendations, and also prioritized packages of interventions. And I'll talk through that as well. Next slide, please. Annie is going to talk about this in a lot more detail, but I did just quickly want to draw attention to the research that the global networks of key populations, GATE, INPUD, IMPACT and NSWP conducted a qualitative research of key populations' values and preferences, which really formed an important part of the evidence, which was reviewed by the guidelines development group. And just to say that it was research which allowed us to understand preferences across different income classifications, across all the WHO regions, with a good spread of different genders and key populations. And I'll leave the rest for Annie to discuss. Next slide, please. So one of the things we did differently in this guideline was to prioritize interventions and put them into these different kind of groups of interventions in the package. And so the first category is essential for impact, enabling interventions. And as I discussed before, really, we recognize at WHO that the key populations, the most important thing to address is those structural barriers which violate human rights and which reduce access to services for key populations. So these are essential in all settings. It's essential to address these barriers in order to meet our goals for HIV, hepatitis, and STIs. The next set of interventions are essential for impact health interventions. And these are interventions which have a demonstrated and direct impact on HIV, viral hepatitis, and STIs in key populations. And again, I'll talk through those in a second. The next was those interventions which are essential for broader health. And these are interventions which might not be part of a national HIV, hepatitis, or STI program, but might not have a direct impact on prevention or treatment of any of those infections, but are important for key populations' health and should be made accessible to them as part of universal health coverage. And then we have a set of supportive interventions. Next slide, please. So those that are essential for impact, enabling interventions, I've just listed here broadly what those recommendations are, but if you go and look at the guidelines, you'll see that underneath each of these broad categories, there's several recommendations. So the first is removing punitive laws, policies, and practices. Second is reducing stigma and discrimination. Third, community empowerment. And fourth, addressing violence. And these are all evidence-based recommendations or good practice statements. And as time goes on, the evidence of the impact of reducing these barriers on key populations, HIV, hepatitis, and STI becomes more and more clear. So, and these, as I said before, are essential in all settings. Next slide, please. Those that are essential for impact health interventions are probably those that you know quite well. First of all, in prevention, we have harm reduction, condoms, PrEP, PEP, prevention of vertical transmission, hepatitis B vaccination, and addressing chemsex. And just to point out that several of these interventions actually would have an impact on more than one of the disease areas, and that is really important. And then we have ones you probably know well, diagnosis and treatment. Next slide, please. Those interventions which are essential for broader health interventions, as I said, they might not be normally offered through an HIV, hepatitis, or STI national program, but nonetheless, they should be available to key populations. And those include anal health, addressing alcohol and substance use, conception and pregnancy care, as well as contraception, gender affirming care, mental health, prevention and treatment of cervical cancer, safe abortion, TB screening and prevention. Next slide, please. We also have a chapter in the guidelines about young key populations, really recognizing the importance of working with and for young key populations, and recognizing that some of the barriers experienced by key populations relate to age of consent laws, as well as the lack of young and adolescent friendly services specifically for key population, and a lack of involvement of young and adolescent key populations in planning and providing services for key populations, and these gaps really need to be addressed. Next slide, please. Now I'm going to talk you through the new and updated good practice statements, and recommendations. This first one related to behavioural interventions is a good practice statement, which is actually an update of a recommendation which was included in the 2014 guidelines. That recommendation was based on some not strong evidence, and also noticing that there is a lot of investment, financial and human resource investment in the provision of behavioural interventions to key populations. We really felt that it was time to relook at that evidence and see if there was additional evidence which would help us to make a more informed recommendation or statement about behavioural interventions. So the question we asked ourselves for this one was, do counselling behavioural interventions which aim to change behaviours such as needle syringe sharing, unsafe drug use, unprotected sex, do those interventions have an impact on HIV, viral hepatitis and STI incidents, or on the risk behaviours which they're trying to change? And what we found was 8 RCTs with the moderate certainty of evidence showing that they did not have the intended impact. They did not have an effect on the incidence of HIV, viral hepatitis or STIs, and they did not reduce those risk behaviours. And this, I do want to point out that I'm talking about a very specific type of intervention, which is a counselling intervention which aims to change behaviours. There's lots of other interventions which are counselling interventions which are useful, particularly for people who are suffering from mental ill health, or also for building a relationship between a service provider and client. But for those interventions which really are aiming to change behaviours, it's important that people understand the limitations of these interventions when they're planning services. And that's the reason why this good practice statement was made. Next slide, please. We had, at the beginning planning stage of the guidelines, we had community members and others asking us to look into chemsex, to understand what can be done to help people who want to reduce the harms associated with chemsex. And so we did the evidence review and took this question to the GDG. For the purposes of the evidence review, we defined chemsex as when individuals engage in sexual activity while taking primarily stimulant drugs, typically involving multiple participants and over a prolonged period. And what we found was that this definition of chemsex is not the same as many other definitions of chemsex, and that people in different countries and different settings define it differently. And when we looked at the research, it was also very hard to find research which fit with this definition that we had used for the purposes of the systematic review. But what was clear was that there is a concern about chemsex, and there are several risks associated with chemsex. Those risks related to injecting drug use, sex that's not protected. And so it was important that we provide a comprehensive and person-centered interventions to people engaging in chemsex to address all these risks and to ensure linkages to evidence-based prevention, diagnosis and treatment interventions. Next slide, please. We have 2 new recommendations related to hepatitis C. The first is about, the question is for people who have an ongoing risk of hepatitis C, and that very much includes people who inject drugs, men who have sex with men, and people in prisons. And they have a history of being treated and cured or spontaneously clearing hepatitis C infection, should they be offered more frequent testing for the presence of hepatitis C. And the evidence that we found basically allowed us to compare a 3 and 6 monthly testing with a longer duration of testing. And what the evidence found was indeed that if you do the more frequent testing, you really find a lot more people with hepatitis C. And if you are able to then link those people to treatment, you're obviously reducing the amount of viral load, which has a public health benefit, as well as, of course, for those people, linking them to treatment and improving their health. So the GDG felt confident in making a recommendation that those people should be offered more frequent testing for hepatitis C. Next slide, please. The next slide, the next recommendation about hepatitis C was related to treatment. This was whether when people are tested for hepatitis C, those people with ongoing risk, should they be offered immediate treatment for hepatitis C? In many settings and many policies actually require a waiting period before treatment is given because a proportion of people will spontaneously clear the virus. And the rationale is that we should wait to see if people clear that before we treat them in order to avoid unnecessary treatment or wasting hepatitis C treatment. In fact, what was found with the evidence review was strong benefits of immediately treating people for hepatitis C after they had been diagnosed, and a strong preference for this amongst the community, as found through the values and preferences study, which I discussed before, and Annie will talk us through a bit more. So the GDG was confident recommending that hepatitis C treatment should be offered without delay to those people who had recently acquired hepatitis C and are at ongoing risk. Next slide, please. We also have a chapter on service delivery, and just highlight a few things which are new in that chapter. We have some learning from COVID. Of course, key populations and the services which are provided to them were affected by COVID, and there was some lessons to be learnt. We also have a new section on self-care. WHO has a new guideline on self-care, and also we have recommendations related to HIV self-testing and hepatitis C self-testing, and really trying to highlight the value of self-care and how that can empower people to take care of their own health. And we also have new recommendation, which I'll talk about, related to virtual service delivery. Next slide, please.
Just a couple more minutes, Virginia.
No worries. So the first recommendation, which was related to service delivery, was peer navigation. We're talking about key population peers who work with their peers to facilitate entry into treatment programs following testing for HIV, hepatitis, or STIs. And you're probably all aware of these type of programs. They've been around for a long time, but WHO has not had a recommendation specifically for key populations. And what we found was that using peer navigators to help key populations after they've tested positive to access treatment has really positive effects in terms of treatment initiation, viral load suppression, and treatment retention. And so the GDG again was able to make a recommendation that peer navigators should support people from key populations. It's really important to note that peer navigators should be adequately remunerated. They should be recognised, receive adequate training, and be treated as equal members of a health workforce. Next slide. Final recommendation to talk you through is related to online interventions. We looked at 3 different types of online interventions: online outreach, targeted health information, and online case management. And what the evidence showed us was that delivery of services to key populations through virtual platforms was as good, if not sometimes better, than a standard of care. And so the GDG again was able to make a recommendation to for online delivery of these services as an additional option. But again, important to note that it's really important that data security and confidentiality are protected, and also to recognise that not everyone has access to the internet, and there are sometimes barriers associated to the cost of data. So it's an additional service, and these limitations need to be taken into consideration. Next slide, please. So I've finished talking through the guidelines, and just what is next is disseminating these guidelines at events such as this today. So thank you again for coming today and listening. And I'm looking forward to talking about this a little bit more over the next hour or so with you all. We will continue to monitor the uptake of these guidelines through global monitoring systems like the Global AIDS monitoring and the Global Hepatitis report. And we're really keen to also work with key population communities to see how they would like to monitor the uptake of these guidelines through community-led monitoring systems. Next slide is just the acknowledgements to the WHO Secretariat, Annette Vester, Anton Zmodalewskis, Nicholas Lumen, Rachel Bagley, Mayvi Di Mello, Caddy Irvine, Laurent Palain, and Belen Dinku, as well as the key population networks, INPUD, NSWP, IMPACT, and GATE, the Guidelines Development Group, and the external review group that was some hundreds of people, including all of our UNAIDS co-sponsors. So it really was a big piece of work that involved a lot of people, and so thank you to everyone who was involved in this. Thanks.
Thanks very much, Virginia, for taking us through this extensive update and revision, the great broadening of these guidelines really to have a much more people-centered approach and an integrated approach. I think clarifying the interventions and making sure that we have the current best practices. So that's really great that we have them available now. And this development of the guidelines could not have been possible without significant inputs from the communities that we work with and support, and that these guidelines will hopefully try to deliver people-centered approaches and services and interventions for. So we're delighted to have Annie Madden of the International Network of People Who Use Drugs, who will give us a community perspective on the development of the guidelines and the research that was involved. Annie, please go ahead.
Okay, can you hear me?
Yes, loud and clear.
Right. Thanks, Tim, for that introduction. Yes, my name's Annie Madden, and I was one of two research leads for INPUD, the International Network of People Who Use Drugs, as part of the WHO commissioned values and preferences research that Virginia has just referred to, that was done as part of updating the Consolidated guidelines. My role today is to take you through a brief overview of that values and preferences research on behalf of all four key population networks that are listed there, so GATE, INPUD, IMPACT, and NSWP. Next slide, please. So what I'm going to do is just a brief sort of overview of some of the key rationale and objectives of the research. I'll take you through the methodology, participant demographics, just to give you a bit of an overview of the sample, and then some of the key results and some concluding remarks. Next slide, please. So the rationale and key objectives for the research was, in the first instance, was to ensure that the WHO recommendations were informed by the values and preferences and lived experiences of the intended beneficiaries of the guidelines. And so, of course, to do that, you need to actually understand what the values and preferences of those key populations are. And so that led to, for the first time, for there being community-led values and preferences research to sort of underpin the work in reviewing the guidelines. And in doing that, it was about identifying sort of the key health priorities for the key populations and their values and preferences towards services. But we also sort of put those health priorities, if you like, in a broader context. And we also looked at some of the structural barriers and also some of the enabling interventions that might help to address some of those barriers to access. Next slide, please. So the methodology we used, it was a qualitative research study, and we did each of the networks, the 4 key population networks, conducted their own community-led research. With the participant sampling was done with the specific purpose of recruiting participants that had a rich and detailed knowledge of and insight into the values and preferences of their community. Participants needed to be over 18. We did the research in 4 languages, so people need to speak either English, French, Spanish or Russian, and they needed to be a member of one of the key population, at least one of the key population groups. In terms of data collection, we engaged regionally based community experts as consultants, and they were overseen by the primary investigators from each of the key population networks, and we conducted focus group discussions and semi-structured interviews. In relation to analysis, once we had collected our data as networks, that data was collated and thematically coded using a qualitative coding framework that was actually developed in a collaborative way across all of the networks. And what that allowed us to do by using a shared coding framework, we were able to identify the commonalities, the themes across the key population networks and the research we'd done individually, and then as well as some of the sort of outliers, if you like, some of the differences between the networks as well. Next slide, please. So at a glance, I think Virginia's already put this information up, but we did 61 semi-structured interviews, 32 focus groups with 229 participants across 69 countries. Next slide, please. The participant demographics. So as you can see here, we had participants from across all of the WHO regions, and approximately 70% of our participants were from low and middle income countries. And we had quite, as Virginia said, quite a good spread of genders across the sample as well. Next slide, please. So I'm just going to take you through some of the key results. So in terms of across the 4 key population networks, the key health priorities identified, importantly, the first one was mental health. Now that in some ways related to the time at which the research was being done, and you can see below one of the other priorities was the COVID-19 pandemic. So some of the mental health issues related directly to that, others didn't and were broader than that. Of course, HIV, STI, hepatitis C prevention, testing and treatment was a key priority, as was harm reduction, gender affirming care, and sexual and reproductive health. Importantly also, you'll see there that structural barriers were identified as one of the key priorities, and that is because, as Virginia also noted, these structural barriers, which I'll touch on in a moment, something that was very prevalent across all of the key population networks and was a feature in all of the research and was identified as a priority in each of the networks' research. Next slide, please. So in terms of preferences for behavioural interventions and perceptions of their impacts or the impact of those interventions, there was a very strong preference for peer-led tailored interventions across all 4 key population networks. In particular, there was a preference for peer-led counselling, outreach, education and information, because effectively across all of the key populations, the participants identified those peer-led interventions as the most effective for them. They also identified the efficacy of behavioural interventions was very much affected by structural barriers that affected access to services, and also of drivers of vulnerability, such as things like policing approaches and prisons and criminal justice broadly, how they impact on people's access to services and interventions, and also the efficacy of those interventions. Next slide, please. In terms of modes of service delivery, the issues that participants across the networks identified as important were the issue of connection, and that was really an emphasis on the need to foster trust, personal connections, rapport in health services. As I've touched on previously, they identified the need for community-led service models, and participants felt that this counterbalanced the stigma and discrimination they often experienced in more mainstream services, and they saw community-led services as offering targeted, sensitised care that was provided in more accessible, confidential, and importantly, safe ways. There was also discussion about whether in-person or online service models were more effective or preferred or valued more. And there was a strong recognition that online services and tools and platforms are certainly becoming more prevalent and being used a lot more. But there was a strong feeling that in-person services are really invaluable, particularly to communities like the communities we are discussing here, where there are real issues around equity of access to online platforms, to devices, to technology. There are real digital divide issues here. So they felt that it was really important to stress that, yes, online, but needing to always ensure that in-person services are not lost in that mix. Next slide, please. Okay, in terms of specific issues around HIV, viral hepatitis and STIs, in terms of, I'll take hepatitis C first, in terms of hep C testing and treatment. Across the networks, there was limited knowledge of HCV testing and treatment amongst most participants, but the exception to this was the INPUD participants, where those participants from networks of people who inject drugs were really quite knowledgeable on hepatitis C testing and treatment, but the other networks, this was not really the case. There was also a sort of varied level of knowledge amongst the networks across the populations in terms of awareness of and access to the pan-genotypic DAA treatments. And also all of the networks identified significant barriers to HCV treatment in relation to cost, in relation to requirements for people to be abstinent from alcohol and other drug use before treatment, in terms of delays. Stigma and discrimination was a major issue, and of course, lack of political will and information for people. Next slide, please. In terms of STI prevention, testing and treatment, there was little knowledge surrounding pooled sampling method for gonorrhea and chlamydia screening amongst MPACT and NSWP participants. There was an emphasis on improving access to rights-based STI prevention services as opposed to periodic presumptive testing, again, among MPACT and NSWP participants. And there was a preference for community-led services, once again, due to stigma and discrimination, criminalisation, violence and marginalisation in mainstream services. Next slide, please. In relation to HIV prevention, the preferences around HIV prevention varied by group and even at the level of individuals, which really spoke to the need for a very peer-led and tailored approach and for a variety of different options to be made available to people. external condoms and lubricant, opioid agonist treatment, needle and syringe programs, and other harm reduction supplies were considered by the participants to be pillars of HIV prevention and extremely important to continue and to upscale. HIV PEP and PrEP was acknowledged as effective but largely inaccessible in many contexts. There was also a feeling that there was insufficient information and misinformation surrounding HIV PrEP across communities, and this was particularly the case among people who inject drugs. And preferred settings in terms of HIV prevention were mobile clinics, harm reduction settings, peer outreach settings, and drop-in centres. Next slide, please. As I mentioned, structural barriers to HIV, STI and hepatitis C services was a major issue that was raised across all of the networks and all of the participants in the research. In particular, issues were raised around stigma and discrimination. This included poor treatment by service providers, denial of treatment, breaches of confidentiality, violence and abuse, as well as internalised stigma and the implications of that for people's access to services. Criminalisation was also raised across the key population groups, fears of legal repercussions when accessing services, punitive policies and practices, including the use of condoms and injecting equipment supplies as evidence in the criminal justice system, exclusion from funding and state health responses. And the final one is a lack of legal gender recognition was raised. That is the lack of gender affirming care and barriers to education, employment and housing. Next slide, please. So in terms of those structural barriers that I've just spoken about, there was the research raised and also spoke about, what sort of enabling interventions might help to address some of those structural barriers. And at the centre there, you can see that at the core, people were calling for a rights-based approach to HIV, STI and hepatitis C services, and that sitting around that must be policy reform to make necessary changes to punitive laws and policies, criminalisation, etc., anti-violence measures, of course, funding and resourcing, particularly to peer-based and community-led services, which are often under-resourced, and community empowerment to allow people to be part of addressing their needs through their own services and programs. Next slide, please.
Just a couple more minutes.
So, okay, so this is my last slide actually. So to sum up, just on some really key concluding points. There was really strong community involvement in the values and preferences research. It was amazing to be able to do this research for the first time in relation to the development of the guidelines, revision of the guidelines, and to have that research across all networks and to be community-led. It was, really brilliant opportunity to be involved in that, and I think it found some really important identified some really important issues and priorities to inform the guidelines. From here, from a community perspective, there is a real need for both the findings from this research, but also the guidelines themselves to be disseminated by networks out into community and to the participants of the research, and also the importance of the continued partnership between WHO and key population-led organisations and networks, because we know that people in the key population networks, we know what works, and we need to be part of the solutions and addressing issues and concerns, and the best way to do that is through partnership and resourcing for community-led organisations. I'll leave it there. I just want to thank all of my colleagues in the other key population networks who are part of this research, and of course the participants in the research from all of our communities, without whom we wouldn't have been able to do the research at all. And thank you to WHO for their work as well. Thanks.
Great, thanks very much, Annie. That was a great overview of the community participation and how it's been an essential partnership for development of these updated guidelines, and drawing attention to the persistent structural issues, which I think the guidelines really have made a key effort to try to focus more on these persistent structural issues that really need to be addressed, and that underpin a lot of the difficulties we have in reaching better coverage of key population programs. So that's really a key issue we have to consider about the laws, the policies, the attitudes, stigma and discrimination, and the exclusion of key populations is critical we address those issues. Yeah, thank you so much. Now we're going to throw it open to the audience for one of two audience polls. And if someone can put the link in the chat for the first, there we are, we have a Survey Monkey. And we're asking you to just give a few words or a sentence about what this first question is about. What are the technical assistance needs that you will require to implement these new guidelines in your country? And if you can indicate your country, that would be great. You can answer the question in multiple languages, not all languages, but we have 5 or 6 languages available. We won't be able to analyze and present the results during this webinar, but they will be analyzed, and we will circulate a summary of what people's feedback has been. So if you see the link in the chat, please go there now, and the question is there about what are the technical assistance needs you will need in your country to roll out these guidelines. That will help us to consider how we support the fuller implementation of the new guidance across different countries. We'll have a few minutes there for people to record your responses, and then we'll move on to the next section. Thank you. I hope everyone is finding their way to the Survey Monkey. Just give us a few words or a sentence about your TA needs. That'll be very helpful. And it's good we've had people putting questions and comments into the chat, and most of them I think have been responded to. So we're trying to make this as interactive as possible, but we have a lot to cover. So great to get your feedback through the Survey Monkey. Well, I hope many of you have found your way to the SurveyMonkey site and have been able to give some inputs there as to what your TA needs will be in your country. We'll leave that link open there so that you can continue to add any thoughts during the next session. But I think we will move on now to a panel discussion where we're going to open it up for some inputs and reflections from different sectors and different partners who've been involved with the guidance. You can see on the slides here, we have a list of participants who we're going to present some questions to. And I'd like to hand over now to Dr. Annette Verster of WHO, who's one of the advisors, the HIV advisors there, who's been instrumental in leading the development of the guidance. And Annette will lead us through the question and answer session. Annette, please take the session.
Thank you, Tim. Can you hear me?
Very well, thank you. Yes.
Good, good. All right, well, thanks very much. I realized that we're already running a little bit over time, so let's try to recuperate a little bit of that in the coming panel discussion. I'm really delighted to have a really excellent panel here. We have someone from the National CDC, the Ministry of Health of Georgia. We have which is Ketevan Stevila, or Ketty. We have Trista Bingham from PEPFAR, CDC. We have Global Fund representation with Matteo Casolato, the World Hepatitis Alliance, Kerry James, and then you may be aware that we are repeating this whole event in the afternoon for people at the other time zone. So for this session, we have two key population representatives from GATE, from the Transgender Network and from the Network of People Who Inject Drugs. And in the afternoon, or for some people in the evening, we have representatives from the MSM and sex worker networks. So let me move straight away to Katie. Thank you so much for joining us. As you know, we have in this exercise, in this particular guideline for the 3 disease areas and 5 key populations, we really have made a difference by highlighting the need to address structural barriers. Before you can provide health services, you need to address the structural barriers. And Georgia has experience in actually doing this. So we would like to ask you if you could share the experience of Georgia and how you were able to address structural barriers. In particular, I think it was for people who inject drugs, but perhaps you can give this example to how you did this in Georgia.
Thank you, Annette. I would be happy to share our experience, particularly for programming hepatitis C interventions for people who inject drugs. You may know that Georgia is among the countries of high hepatitis C burden. And I don't know, something is wrong with my screen.
Yeah, the video is frozen. But we can hear you very well, so you can...
Oh, okay,
yeah.
All right, I'm really sorry. So we are high burden Hep C country, and population-based SERA survey showed that 5.4% of population had active hepatitis C infection. We did the same measurement for people who inject drugs, and 54% of population had active infections. So this population was prioritized by our. We started screening, and we integrated this intervention in current harm reduction programs. And we offered referral to treatment at specialized clinics, but we observed that they had huge barriers. First of all, it was criminalization of drug use, high level of stigma, fear for discrimination, also geographic access. our technical advisory group that closely monitors elimination program has pointed to these structural barriers to the government and said that we really had to do something in order to achieve elimination in a very, very short period. We actually had very short timeline for first phase of elimination. They did not change the law, but they eased law enforcement, and police would not chase people who inject drugs if they were enrolled in harm reduction programs. Furthermore, Ministry of Health simplified regulations for opening hepatitis C treatment clinics, and it was kind of a possibility to start integrated clinics at harm reduction sites. The same development happened at primary healthcare levels, so geographic access to these services was considerably improved. In addition, FINE's demonstration projects supported our integrated sites through provision of molecular testing instruments, gene experts, and test cartridges. So it created centers where people who inject drugs could receive comprehensive service for hepatitis C at harm reduction sites. And those harm reduction sites that could not or did not start this kind of integrated clinics, we supported through peer navigation, case support. We supported organization of patients, schools, and adherence support counseling sessions. Initially, this initiative was developed with support of the Global Fund for HIV Care, but we were able to redirect some of resources to support people who inject drugs who required follow-up for hepatitis C diagnostics and treatment. So at the end of 2021, we did repeated sero survey, and we observed that active infection prevalence went down from 54% to 17% in people who inject drugs, which is remarkable progress on the road to elimination. As you know, PVID are frequently co-infected with hepatitis B also. And our patients were asking, you're doing this much for hepatitis C, what about hepatitis B? And we are very happy that this year, finally, we launched hepatitis B elimination program as well. And this is great that this consolidating guideline will provide us with tools and interventions that will be effective to implement hepatitis B elimination initiative. I also wanted to talk about hepatitis C self-testing, because it was mentioned by the importance of switching to some virtual interventions, especially what we learned from COVID-19. And right now, together with FINE, we are testing online distribution model for hepatitis C self-tests among people who inject drugs and MSM. We have two distribution models. One is courier service, another one is peer delivery. And at the end of this study, we hope to provide strong evidence, because this is randomized controlled trial in support of integration of hepatitis C self-testing along with HIV self-testing in viral hepatitis and HIV programs. At the end of September, in Tbilisi, we will be hosting HIV Sustainability Summit for our region, ICA region, together with MDF and also Ukrainian Alliance. And WHO will be presenting consolidated guideline to HIV program implementers in our region, and we hope it will inform our colleagues and also will help us to accelerate implementation. At country level, for implementation readiness, we plan to update key population protocols and the standards of care, and also provide training to healthcare workers, community workers, and law enforcement agencies. It was mentioned by Anne that it is critical to sustain and expand service delivery by community organizations, and we are happy that we will be able to follow this recommendation, and a large percent of our programs will be implemented by community organizations. In addition, we plan to make stronger community-led monitoring system, programs like REACT that use community members themselves to work as paralegals and provide, they will be able to document legal cases and human rights violation cases. So we have big plans for accelerated implementation of new guideline, and we are very happy and would like to expand our great thanks to Guideline Development Group and to WHO.
Thank you so much, Dr. Katie. You mentioned everything. You mentioned hepatitis, you mentioned online service delivery, community-led service delivery, and monitoring, the addressing of laws and legislation. You mentioned COVID and the impact, and already your plans for updating your own guidelines and disseminating these. So thank you so much.
Thank you.
I'd like
sorry
to
for video again.
I'd like to move to Trista. Can you hear me, Trista Bingham?
Yes, I can.
Very good. Thanks for joining. It's very early for you, I realize.
I'm an early riser, so it's fine.
Well, that's really good. So of course, PEPFAR is a critical partner in the whole global HIV response, and in particular with regard to key populations. So you're representing both PEPFAR and CDC, and I would like to ask you what you see as the most important aspects of these guidelines, and how you, as an implementer and a donor, see of working or disseminating these guidelines and using the new recommendations.
Thank you so much, Annette, and everyone. And good day, everyone. I'm so happy to join you, even though it is on the early side here in Atlanta. But I'm here to convey what we in PEPFAR's KP community of practice view as the most important aspects of these WHO guidelines. And I'd like to start by noting that the new global ambassador, John Nkengasong, has highlighted health equity for priority populations, which includes key populations, as one of PEPFAR's strategic pillars moving forward. And so these guidelines are very timely in that regard. PEPFAR has always followed the WHO guidelines, and while STI services have always been part of KP guidelines, there is now added focus and emphasis, which we can use to really insist that STI treatment and control be made available for all KPs in our programs. So with the emphasis on STIs in these consolidated guidelines, WHO is underlining the importance of STIs to HIV transmission and control, and vice versa. So for too long, PEPFAR countries have not felt empowered to include and emphasize STI screening and treatment in their programs. Not only is STI screening and treatment appropriate medical care for key populations, but it also provides a needed service that can be a gateway to HIV prevention, testing, and treatment. So by encouraging PEPFAR countries to make STI services standard care for key populations, we can reduce STI and HIV burden among key populations and their sexual partners. Next, in all honesty, young key populations have not been equitably served in the implementation of our PEPFAR programs. Explicit naming of young KP as a group to be served in these guidelines is critical to ensuring that they are in national policy considerations, national strategies, and programming. The consolidated guidelines do a nice job in highlighting the persistent gaps in HIV and STI programming when it comes to young key pops. We and our PEPFAR program planners and providers need to do better at serving young key pops. We need to involve young key populations themselves and appropriately trained KP peers in the design and delivery of these services. We need to ensure that they are safeguarded from harms, but they must also feel welcome to access the healthcare they need. Peer navigation has long been undertaken, but is often a voluntary component of our program implementation. These guidelines emphasize the explicit importance of peer navigation in KP program implementation. This means that peer navigation can be better budgeted for, that opportunities for peer leadership can be made available, and they can be better integrated into direct clinical provisions. These advances will help peer navigators to actualize their role as advocates for their peers. And then in closing, PEPFAR is building a new sustainability framework in our work. Strengthening national and local political, programmatic, financial, and community leadership are critical elements of this work. Within this framework, we will be strengthening our support for KP-led community monitoring, supporting KP-led organizations, and tackling laws, policies, and other structural barriers that continue to fuel these inequalities. Over the past few years, PEPFAR has established a platform through community-led monitoring to help ensure PEPFAR beneficiaries are receiving quality person-centered services. While there is still room for improvement in the delivery of HIV and STI services for key populations, we have seen gains and even the acknowledgement from country governments that KP deserve competent and appropriate services. Hopefully, Ambassador Nkengasong's leadership toward health equity for priority populations will catalyze even greater progress for KP-led organizations and person-centered services that directly benefit key populations. Thank you.
Thank you so much, Trista. This is all excellent, of course, to hear the focus of PEPFAR on key population, and in particular with directly referring to the need to integrate STI and HIV and the added benefit to doing so for both disease areas, and highlighting some of the new recommendations with regard to community-led organizations monitoring, peer navigation, and also the need to focus on young key population. Thank you very much. I'd like to move from PEPFAR to global funds. Matteo Casolato, are you here?
Yes, Annette. Hi, can you hear me well?
Yes, hear and see you very well. Thanks for joining us, Matteo. Of course, Global Fund is funding programs for HIV and a strong focus on key populations. And we were both in particular in lower middle income countries, and also some of these countries are transitioning out. So we would like to hear from you how our guidelines can help you to advocate, to prioritize, for countries to prioritize key populations, both in current grant making, but also beyond, once countries go and become out transitioned countries. Thank you.
Thank you, Annette. It's a complex question.
Sorry, I narrowed to two questions, really.
No, it's good. It's good. First of all, let me just thank Global WHO, but also the GPC and the South to South Learning Network for having Global Fund here in this panel. Just wanted to say that obviously Global Fund, welcomes these updated key populations guidelines, not only because we rely massively on these guidelines when we prepare HIV info note, and thematical briefs and various other documents, modular frameworks, for instance. So not only we rely on that, but they come at a really right time. As you know, Global Fund will, from starting next year, embark in the new funding cycle with new concept notes being written, countries busying themselves writing these new concept notes. So having this tool in their hands, it's really, really great timing. So thank you for that. Trying to answer maybe the first part of the question, then moving on to the second. So how can these guidelines help us prioritize key populations? I would say there's probably, in my opinion, three main reasons. The first one, it's really about the fact that these guidelines provide evidence-based approaches and evidence-based interventions. And this is always important, but it's particularly important with key populations programming that is often of a contested nature. And, we know very well how the type of abuses and human rights violations the key populations members suffer when they access services. So, this is really, to us, really an important tool that can help, make the case for these interventions, for their inclusion in the concept notes. So that's my first reason. Second reason, I think, and many of you spoke to that, and which I think is really, really important, is how addressing structural barriers, how the enabling environment is, the importance of the enabling environment is front and center in these guidelines in ways that I don't think was ever done before. And so, this is really important for all of us, for advocates of addressing harmful laws and policies, for tackling criminalization of key populations, and pushing for their protections instead. So it's really, really great to see that there's a place for that in these guidelines, well defined, understanding, of course, that biomedical interventions alone will not get us where we need to be in the response. And my third reason, I think, is one about prioritization. In a way, this guidelines also help us prioritize interventions. And Global Fund, as much as as much as we would like it to have infinite resources, it does not. So it's important to make sure that we are capable of picking at times. And I know it's a word we wouldn't like to hear, but like finding ways to prioritize the interventions that are more likely to have an impact on HIV incidence, for instance. When speaking about incidence in this particular case. So yeah, so that to me is an important part. I'm not going to go into what kind of interventions. I mean, you, Virginia, and did a great job in highlighting some of those. Just to say maybe that on harm reduction, of course, will keep on being being a central program for us. Adding to that, also trying to take care of the needs of people who are at risk or have hepatitis C, a risk of acquiring or already suffering from hepatitis C. So that's maybe something important that we would like to see also included in the new concept notes. And on behavioral interventions, quickly, just to say that totally taking the point that WHO was making, and also the networks have been making around this, we've changed in the modular framework our BCC category to health, communication, and demand creation. So that's where it's going to be found, right? Those type of interventions that speak to empowerment and to supporting people using, prevention options. Now, coming a bit to this, if I have time, I'm coming to the second part of the questions, thinking more about, thinking about countries that are transitioning out of global fund support, and how can we make sure that even in those countries we keep on key populations keep being included not only as recipients of services, but also as providers, as designers of services that relate to them. My first thing that, the first thing that I would think about is, of course, how the Global Fund strategy has two objectives around this, two contributing objectives, mutually contributing objectives. One is about engagement and leadership of the people most affected by the three diseases, but also one around addressing, maximizing equity, gender equality, and human rights. I think that if we make sure that we do keep on working on these two elements, and I'm going to tell you in a bit how, I think that that's the key to them seeing global key populations programming still prioritized after Global Fund transitions out. Mechanisms like at least I was talking about those, for instance, community-led monitoring are vital to make sure that we can keep the pressure on governments to include key populations in their programming. But not only, I think also all our mechanisms for social contracting. There's a bit of a movement in communities that are addressing, that are in part of the HIV response, to more and more being contracted to provide services by their government. And I think this is the right way to to go into finding more and more ways for governments to support and actively contract civil society and key population-led organizations in providing services to key populations. And I'll stop here. I hope that's more or less one answer to you. Thank you.
Thank you very much, Matteo. And I won't summarize your question because we're a little bit behind with time, but for highlighting the hepatitis issue and the behavioral interventions with regard to prioritization. So I'd like to go to the next panelist, Carrie James of the World Hepatitis Alliance. And this basically, can you hear me? Are you here, Carrie?
Yes, I can hear you, yes.
Good, oh, there you are. Thank you. Thanks for joining as well. And as you know, we have been trying to bring together 3 disease areas because there's a lot of overlap in the responses and the risks. And we were wondering how you see from the hepatitis perspective these guidelines and as an opportunity, or do you see also maybe potential risk related to additional stigma while viral hepatitis in many countries may not be usually associated with key populations? So just I'm trying to keep the panel in time. So if you could respond to this question in 3 to 4 minutes, that would be really appreciated. Thanks, Gary.
Sure, of course. Thank you, Annette, and thanks to the organizers for inviting us to be here. And thank you so much to WHO for this new set of guidance. I mean, I think it's so important that we stop thinking about diseases in silos and really focus on the needs of individuals in our communities. And I think for people living with viral hepatitis in key populations, I mean, the main benefit and opportunity is going to be an increased quality of life, right? Less appointments in different places, and more making every contact with these key populations count, which we know is so important. And I think the other really great thing for the hepatitis community is really the kind of solidarity with key population advocacy networks and community-based organizations. I mean, the hepatitis community, tends to be small grassroots civil society organizations, without much infrastructure, who can often feel isolated in their work. So I think the idea of bringing these things together, creating wider networks, more cooperation, more learning. I mean, we know that, how well developed and how powerful, key population networks are. And we really struggle in many parts of the world for people living with viral hepatitis to find their voice, to find the courage to step out and to, demand better services, to fight stigma and all these other things. So I think, the opportunity for us to work together in a shared vision of the future around stigma and discrimination is so important. And just to kind of go down the stigma point. I mean, I think we've, those of us who've been around for a while are familiar with this argument that, that we shouldn't talk about key populations and the disease response because, the general population won't be comfortable with it. It'll lead to more stigmatization. It'll limit services. But I mean, it's been very clear over a number of years that, this attitude has led to more inequality, more suffering in key populations, and really with big barriers for the progress of kind of disease, disease elimination responses. So I think we just have to really, neglect these, reject these kind of arguments and really realize that, two of the main drivers of stigma are, misinformation and invisibility or lack of personal contact that people have with these populations. And we need to work together to combat both of these things together, both as key populations and as people living with viral hepatitis. And I think finally, the opportunity is really around support and around financing. Over 1 million people die of hepatitis related illness every year. And not to, imply that it's a competition, but that's more than HIV and malaria combined. And yet the support for hepatitis elimination is a fraction of the amount that's available for other organizations. And we really welcome the new concept note by Global Fund, which really expands the the possibilities for support around hepatitis in key populations, which is a huge step forward. And we really welcome UNITAID, including hepatitis C in their new strategy, and we really encourage more international donors, more countries to really address the global hepatitis burden. Organizations like PEPFAR. I mean, it was a little disappointing that that Trista didn't mention hepatitis in her statement. And we know that there are pockets within PEPFAR programs, especially in Asia, where it's like self-testing for hepatitis have been integrated into key population programs within PEPFAR programs that have a great success. We really hope that more global donor organizations like PEPFAR, like the Gates Foundation, really embrace the entirety of these guidelines and really, we often say it's small steps by big organizations that can make a huge difference in viral hepatitis. And we really hope that these guidelines will be another part of that process. So maybe I'll just leave it there. Thank you so much.
Thank you very much, Carrie, and thank you for making these excellent points. I just wanted to highlight the fact that PEPFAR and the Gates Foundation have supported the development of these WHO guidelines. So just want to make that point. Maybe just going to our next panelist, Judy Chang from INPUD. Judy, are you here?
Yes, I am. Thanks.
Great. Hi, good to see you. Maybe we can just stay with hepatitis for a moment, because it's also so relevant for your community. And of course, we've worked very closely together on the development of these guidelines. But perhaps you can just focus in the next few minutes and say something about how, in particular, the hepatitis recommendations will change your advocacy agenda for drug user health. Perhaps you can say something about that. Thanks.
Sure. So as Virginia mentioned earlier in her presentation, there's 2 new recommendations on hepatitis C. And I think broadly, it won't necessarily change our advocacy agendas of people who inject drugs, but gives additional ammunition and leverage, to our existing and long-standing community asks around hepatitis C, knowing, of course, that it's a critical but often neglected health issue for people who inject drugs, and the global prevalence is estimated at around 40% for people who inject drugs. So the first recommendation, of course, was on hepatitis C testing and more regular hepatitis C testing that should be offered. And I just wanted to re-emphasize the 2 remarks nested within the recommendation, and emphasize that these were really shaped by community values and preferences and advocacy agendas. The first one being that testing, must be voluntary and should not be used to further stigmatize key populations. And the second around the importance of, making it accessible, right? And that being that it should be linked with harm reduction programs and primary prevention services overall in order to, reach people who inject drugs. And this is because a lot of the times, our only contact with health services is harm reduction centers, because of criminalization, stigmatization. So the second recommendation, of course, was on hepatitis C treatment. And this is very important given the lack of access to affordable treatment for hepatitis C, particularly amongst people who inject drugs. And this is because, one, there's been and still is discriminatory policies that have excluded people who inject drugs from being eligible and receiving hepatitis C treatment, even where it is accessible and affordable. And we can use the WHO guidelines to advocate against this blatant discrimination. We can't keep accepting that people who inject drugs are always last in line. The second, part of the recommendation as well is critical and important in that offering treatment without delay is key, as there are too many criminalized populations that are lost to follow-up for many complex reasons. So, we need to look at making it as easy and simplified as much as possible. As above, also with the testing recommendations, the values and preferences again emphasize that treatment should not exist in isolation from linkages with and integration with prevention programs. As Dr. Ketevan stated before, you know, specialist clinics are not always the best ways to reach people who inject drugs. And these, you know, these services really need to be integrated and linked with primary prevention. So I think these new grade recommendations on hepatitis C can be used by drug user-led networks and key population-led networks in countries to push for greater investment and political will to address hepatitis C. And as Matteo mentioned before, I think it is, you know, huge progress that hepatitis C services are now included within the Global Fund modular framework. And I think it does present a real opportunity coming up to promote drug user health.
Great. Thank you so much, Judy. Erica, are you there?
Yes, I'm here.
Hi, Erica. Thanks for joining. Last but not least, you've been very much engaged in the development of these guidelines. How do you see the next stage of dissemination and your role in that? We are very pressured for time. I'm really sorry about that. I'm not sure what happens after the time goes up, but we need to keep it short. We probably can't do the next. There's basically too much to discuss when we try to discuss all populations, all disease areas. So please, Erica, what do you think is critical for you now next?
Yeah, I think I'm going to be very brief, and you know, I fully adhere to what all the other speakers have said, but very important, I think, is the role of how communities will play in the process and how we'll be able to work together with the governments, with the states, with other partners in developing and the rollout and the implementation, the eventual monitoring of implementation and whole of an accountability. First of all, for community perspective, this is an amazing and powerful advocacy tool. It gives us the opportunity and the tools to be able to come to our countries and be able to advocate for the inclusion and the update of national guidelines and the inclusion of the recommended packages for our guidelines. I cannot stress enough how important it will be to work together to be able to reach the goals at country level, and specific issues that really important is the structural barriers that cannot be done by a particular group, but it needs the collective work of everyone to be able to address them and remove them where if possible. But I think there's huge opportunities of all what has been identified, both in what is included for all key populations and the section specific for trans and gender diverse people, and for the other key population networks, because it gives an opportunity also to continue the work and improve the quality of life of communities based on the interventions. I'm going to leave it there for now because I know we're pressed for time.
Thank you so much, Erica. Really appreciate being short. It's clear we have a lot to discuss here, and it's very difficult and challenging to put this in an hour and a half and in a short panel discussion. Tim, I'm going back to you as the chair of the overall event.
Thank you so much, Annette, and thank you to all our panelists. Those are really great, diverse reflections, and as you say, Annette, it really shows the depth and breadth of the new guidance and how it has really required a huge inputs from so many perspectives. And I think WHO is really to be congratulated that you have developed this. And I've got some good news that finally UNFPA is able to endorse the guidelines. So we will be happy to add our support to them and to the rollout. We're going to have to wrap up. We've run over time, but thank you so much to all the speakers and all the presenters, and thank you to WHO for giving us this overview. We've put a link to the the guidance in the chat as well as in the Q&A. And really, we look forward to working together in rolling out what is really the current best practice on how we support and work with key populations and provide real people-centered services to meet broader needs, not just HIV. And I think the representative from the Hepatitis Alliance hit the nail on the head there, saying, you know, we've got to move away from a disease perspective to a person perspective. And when anyone accesses health services, we need to see what are all their needs, not just specifically on HIV. So an integrated approach. Thank you very much again. We'll call it time now, and we will share the presentation, we'll share the recording, and we'll share the summary from the 2 SurveyMonkey response polls that people have added to. So I wish you all well, and we'll close the meeting now. Thank you very much.
Thank you.